Today I'll be speaking on airway devices. I sincerely thank all my patients and surgeons for placing their trust on me throughout the journey. The importance of appropriately functioning equipment is in an emergency situation not only rests in the fact of the equipment in itself, but also gives a great psychological support to those dealing with the emergency. The preparedness, being prepared for intubation, equals to being prepared for any emergency. So first of all, make a plan, build a kit with the equipments which you are comfortable with and are knowing the equipment well. Be informed of its advantages and disadvantages. An idiot with a plan. Since morning, all the lectures we are giving you this key, a plan and plan and plan first. You have your plan A, B, C and D in place before you begin the case in the PAC itself, right up to the extubation. So an idiot with a plan can beat a genius without a plan. That's where the DAS, IDA, the ASA, the ANZA all have come out with different guidelines. There are almost 38 guidelines, all saying almost the same, that is plan A, B, C, D. This is a simple overview of DAS guidelines from which we will plan our airway devices and make your difficult airway trolley or cart accordingly, consisting the devices nicely placed in the first drawer, the plan A device, B device, C, D, the fiber optic equipments, your video laryngoscopes, your flow charts, everything, so that anybody who enters the OT just picks up this irrespective of whether he is a regular or not. So coming to the first plan, that is direct laryngoscopy and tracheal intubation. The main priority throughout all the plans is to maintain the oxygenation over and above everything else and not to give trauma to ruin the future attempts at intubation. Knowing the two curves of the oral line, that is the primary curve which extends from your incisors to the laryngeal vestibule, and the secondary curve is beyond the laryngeal vestibule. So you can see that the curves are in opposite directions. Okay, then you have to know these curves for adequate mask ventilation, laryngoscopy, and our aim is to flatten this primary curve to get the line of sight of the intubator to the secondary curve, because the basic principle is laryngoscopy, inserting the blade, viewing the glottis and passing endotracheal tube. So to get that, you need to have the oropharyngeal oral axis, the pharyngeal axis and the laryngeal axes in straight line. Okay, so as to get the practitioner's eye in alignment with the vocal cord. You can see how much the position changes. No? In the neutral position, the primary curve and the secondary curves are pronounced, which in the sniffing position, the primary curve is flattened and these two curves are in line for intubation. So the laryngoscopy is divided into two phases, that is the static phase and the dynamic phase. The static phase is one which what all things you do in the static phase improves your intubating attempt in the dynamic phase, okay, and it improves the success rate. So what are the static phases? That is the pre-oxygenation, positioning, apnea oxygenation. So accordingly you keep your devices ready. Okay, so any of these headrests, these are also airway equipment devices, because these are very important and mostly neglected thing, that is the static phase. So or any of the headrest, whichever you are comfortable with, should be there, and you have to see the patient also, which suits the patient best. And this is the rapid airway management positioner, which is an anesthetist friend, mainly for obese patients with increased BMI. It improves the upper airway patency, decreases the work of breathing, and prolongs the safe apnea period. You can see that if you do not have this is ready-made available and FDA approved available in the market, but if you do not have, you can use the pillows and bed sheets and give the patient position so that the ear to sternum is in a straight line. Okay, this opens and improves the airway. And Pre-oxygenation. Pre-oxygenation cannot be, the benefits cannot be denied. It helps in denitrogenation and also in apneic oxygenation throughout your intubation attempts. And if you are using a high flow nasal cannula, which is recommended by the IDA, around 15 liters of oxygen flow, you can, it continues up to intubation. It definitely increases the no desat time. I for once, I'm rarely, 90% cases, I'm not masking my patient, not using bag mask since COVID time, giving high flow nasal oxygen and apneic insufflation till my tube is in place. These are various anatomical face masks. See which you prefer, and according to the patient, pediatric, edentulous, or obese patients, which fits, and you have to keep them ready. Oxygen delivery mask. The nasal prongs goes in right from the patient enters the OT. Before you, first you put on the oxygen, and meanwhile, while the patient is getting pre-oxygenated, the monitors and rest are attached. Even the drug preparation can be done after the nasal prongs are in place. And Venturi color-coded masks are available, and also masks with oxygen reservoir bag. These are mainly for post-operative period. The transnasal humidified rapid insufflation ventilatory exchange, that is THRIVE. This improves the delivery of oxygenation at variable concentrations. It reduces the work of breathing, provides CPAPs, assists in carbon dioxide removal too. This can be used in sleep apnea syndrome when you're doing an awake craniotomies. You can improve in your ICU patients with various comorbidities. This helps when nowadays THRIVE is available post-COVID at most of the ICUs, and in the OR you can ask whether your HFNO is working. Please ask for it. Otherwise, we do not know whether this hospital has or not. Airway adjuncts. Various airway adjuncts, the Guidel's airway, everybody knows it. Modified Guidel airway is available in your fiber optic table today, and the entire roof of this Guidel is removed, and hence it allows fiber optic intubation via. So in an unanticipated difficult airway, this modified Guidel airway or an articulated oropharyngeal airway will help, where you can intubate through this directly. Fiber optic bronchoscope reaches your laryngeal vestibule, and it saves your time and reduces the intubation time. Airway adjuncts, nasopharyngeal airway, this also can be used in pre-oxygenation. The mask can fit over it, or you can attach your 15 adapter on the nasopharyngeal airway and give the oxygenation can reach the laryngeal vestibule directly. Even a nasopharyngeal airway can be slit. Suppose a patient like Sir showed the picture with less mouth opening, you can use a nasopharyngeal airway. Before fiber optic, you can slit it and put in the fiber optic, and while the fiber optic is entered the trachea, you can remove this nasopharyngeal airway and railroad the endotracheal tube. These are various kinds of endotracheal tubes. Know and keep things available which suits your patient. Especially you have to use failed attempt of the routine for anterior larynx. You can think instead of going again with the same thing, you think of a soft tip or a flexometallic endotracheal tube, because it prevents the abetting of the tip of the endotracheal tube against the anterior subglottic wall. These are different kinds of laryngoscopy. This has to be a laryngoscope. This has to be pre-checked. The handles, you may need a straight Miller blade for long epiglottics or a retromolar intubation. Trupti blade with a folding anterior distal tip can help in visualizing the glottis better. Now, coming to all this is, people do not check their laryngoscope when you have a video laryngoscope. So many video laryngoscopes are available in the market. As Balaji sir said, it eliminates the need for a direct line of sight, thus allowing us to stand tall and erect. As an anesthetist, we have been bending throughout our life, right from 1945 when Macintosh came, and 75 years later, we are standing tall and erect because of video laryngoscope. But disadvantages you have to remember: you can see but you cannot pass. That is the difficulty. You increase as intubation time initially, it gives a false sense of security, especially when the mouth opening is good, the surgeon says mouth opening is good. You have to remember it doesn't take care of the secondary curve, It is just flattening and reaching you early to the laryngeal vestibule. But the secondary curve, which the atlanto-occipital joint, suppose the patient has a cervical spine or a fixed atlanto-occipital joint, it gives a false sense of security. The tube doesn't, you don't reach the glottis. Loss of depth perception is there, obscured view by fogging and secretions. If you reuse the disposable blade, you get a lot of fogging. You need extension, and there is good learning curve in this, and it is same with different scopes. You have to adapt yourself. There is a fixed handle or camera insertion is a problem, especially in large breast, obesity or short neck. Advantages you can see here. There is no line of sight. I'm standing straight. Limited mouth opening you can give, and less time is wasted in cricoid pressure. People around you can see, and they can assist you immediately with a bougie, a laryngeal mask, or a suction if needed. It causes less trauma because of less forces needed, and you can also use a video laryngoscope for assessing the patient in the PSC. Now, how to choose a video laryngoscope? The blades, whether it is detachable, is better because sometimes you have large breast and a fixed screen to blade. It doesn't allow you to insert the tip of the video laryngoscope. Thin blade gives you physiological fit, and small blade can pass through a small oral opening. Camera should be adjustable viewing angle, giving good megapixel. Disconnecting between the camera and the blades, you have to take care, especially the Medicam one, which keeps on disconnecting when you're doing the laryngoscopy. Battery, it should be good rechargeable lithium battery for super long endurance batteries. Blade strength, especially if you're doing bariatric surgeries and obese patients, you have to go for metal blades, especially a curved D blade. Now coming to adjuncts, bougies, various bougies are available. Preferable is a ventilating bougie with a adapter, universal adapter, through which you can give oxygen also. When you are alone, how will you use it? This is a kiwi grip. You railroad the endotracheal tube preemptively and hook the proximal end into the lateral eye of the endotracheal tube. And once the tip of the bougie passes beyond the vocal cord, you use your index finger and flip the bougie away from this thing, and then you can pass the endotracheal tube. Remember, you can also use it, especially the soft tip one, as an airway exchange catheter for extubation. These are the rigid stillets which are not in use any longer, but then it can save a life. Magill's forceps is an extremely useful equipment which has to be there. If you can, you get a clot or a thick mucus plug can be easily removed, and if at all you break a teeth while intubating. Okay. Now coming to plan B, if all these repeated attempts of intubation, according to the guidelines, that is 3 attempts, and you are maintaining the saturation, ideally I would say if a trained anesthetist, he's put in a laryngoscope inside, he knows whether he can intubate or not. He can just give one attempt and he realizes he cannot, keep the laryngoscope in place and just take in any of the SGD. Once you declare the failed intubation, within few seconds, you can just keeping the laryngoscope in place. You can take an SGD and insert, and hence whatever SGD you have should be always ready, unwrapped and lubricated. These are the various SGDs. The first generation is no longer in vogue. You prefer the second generation, but if you do not have a second generation and you land up in a cannot intubate situation, feel free to use the first generation also, because even if you cannot ventilate, it can give you enough time to call for help, call for an expert by giving apneic oxygenation. Only thing is you have to take care not to increase the airway pressures more than 20 centimeters of water. Now the latest entrants are Blockbuster, and the Telefax company, the LMA Gastro and LMA Protector, which comes with a cuff pressure monitor. Okay, all these will be explained in your workstation today. So I'm not going into the detail. Only thing is that Fast Track, which was an intubating LMA, it was a first generation, and now we have Blockbuster, which is a second generation. And also the tube coming out of the Fast Track, it is an angle of 45 degrees, whereas at the Blockbuster, the tube comes out at 30 degrees. Okay, and it has the Blockbuster has a Parker tip pen which allows it to slide easily into the trachea and gives almost 99% success rate. These are various other LMAs which I'm just mentioning, SLIPA, the BASCA, which will be shown on the table. And this is a C-Track. C-Track, it's a video along with a Fast Track. So you can see while the tube is going in on the screen. Cuff pressure monitor is very important for an SGD to prevent the lateral pressure changes. These are emergency double ballooned king laryngeal tube, that is a combi tube, and these are perilaryngeal tubes, okay, which comes with a cobra-like head. This is there on the table, you can see. And this is Alicia. Okay, Alicia has a ventilating port and separate from the bronchoscopic port. So you can keep ventilating while you are doing a bronchoscopic intubation. Okay. While keeping an SGD, you have to remember that it's a very forgiving device. You will get good graph, ventilation graph and everything, but if there is misplacement, it will not show very easily. So you have to keep in mind that in a difficult airway, the gastric insufflation can occur. There is a chance. So you have to understand that and keep a watch for that. Otherwise, you'll be landing from frying pan to the fire because you do not want aspiration at this level. What happens when you have failed to ventilate the patient with an SGD? So you come to plan C, that is a declared failed SGD ventilation and failed bag mask ventilation. So you start with face mask ventilation, but with the saturation being in 100%, you have to start thinking now for your front of neck axis. Okay, so you do not wait for the saturation to fall. You keep a very low threshold for fauna. So right from the beginning, plan A, you should start thinking about fauna. Okay, keep arranging, maintain the oxygenation, call for help, and the next plan should be ready. So that is what the vortex takes care of, the limitations of all the guidelines. The guidelines gives you fixated errors like keep three attempts of this, 3 attempts of that. You lose precious time. Okay, so you have to decide as early as possible for fauna with the patient being well oxygenated and having good saturations. So maintain the oxygen priority at all levels. If possible, at this level, awaken the patient and postpone the surgery. If not possible, then you go for plan D. Okay, that is emergency front of neck axis. Now in front of neck axis, you have either a needle cricothyroidotomy or a scalpel cricothyroidotomy as emergency procedures. The mini tracheostomy sets were available from Fortex, which are not there in the market now. They used to come with a rigid stellate over which the 4-number endotracheal tubes were loaded already, So take an 11-number blade, take an incision, feel for cricothyroid with stellate itself and just go in. It was very hard, but for an emergency, the instrument should be easily available in all the OTs and you should be familiar with it. Okay, so a 10-number blade, a bougie, and a 6-number ET tube. These are available in most of the OTs. So keep it aside with a 2cc syringe and an 15-number universal connector attached. This should be present in all the OTs in your last drawer. Okay, do a good laryngeal handshake. All these will be explained later in the session by Dr. Sujata for Fauna, so I'm not going into the details. The needle cricothyroidectomy, because it causes a lot of barotrauma and injuries in the posterior, in the tracheal regions so it is avoided and it is out of vogue, not a preferred technique. But if you do not have anything, this can be used for maintaining the oxygenation. A simple GR circuit you can use with a needle and a 2 cc syringe, and you can use it as a venturi. Percutaneous tracheostomy sets are available which will be taken in the workstation, and jet venturi, ventilation and ventrine will be explained in the next lecture and on the table. Now, anesthesia is not a one-way ticket. You have to book your return journey too. So that is, you have to start planning about your extubation. The extubation lecture is the next, but I'll go through the equipments now. Entry catheter. Entry was also a game changer, where entry catheter was used initially at a hospital at Liverpool. Now the hospital is called as Aintree Hospital. They have named the hospital itself as Aintree. Now, once you pass the SGD in your plan B, you can, when you're selecting an SGD, you have to see whether this case you're continuing as a surgery or it is a stopgap. You can take a SGD in such a way that you can intubate through it. So preferably you have to take an intubating LMA. If you do not have an intubating LMA, see that your fiber optic and your endotracheal tube can go through that LMA. Okay, so an LMA like an iGel or Paragain is preferred over Supreme or Procil in such a case. Okay, so you can pass a fiber optic scope loaded, the Aintree loaded over it, and leave the Aintree and remove the fiber optic and the SGD, and then again load the fiber optic with the endotracheal tube and pass over the Aintree, and you can pass the endotracheal tube over the Aintree into the trachea. Now this is airway exchange catheter. Okay, this is lengthier, so it cannot be used for, it is more longer than your fiber optic. It cannot be used as a intubating, but it adds, it goes through the ventilating port or the exchange catheter through the elbow connector. Okay, it can go through the tube, and for difficult intubation is mostly a difficult extubation. So you can leave this place and keep oxygenating, and this allows you to, intubate in case of emergency post-extubation. Now, what is the take-home message? This kind of thing, almost all the OTs, when they begin, they have nicely labeled in, but is this useful for us? No, there's a lot of chaos when things go wrong. I'll just show this small video. This is a case of an Elaine Bromley case. She had come for a simple ENT case. Okay. See, there is no pre-oxygenation. The saturation is falling. She then starts, she directly went for SGD. Saturation keeps falling. No call for help. Nothing is ready. Already. Still, she is only attempting. She's not giving it. There is trauma caused. There is an ENT surgeon in the premises, but he is not called. See the trauma. Now they change hands. There is bradycardia, hypoxia. Okay, he too cannot intubate. They had a fiber optic there. This patient landed up brain dead. For 13 days later, she died. Her husband has made this mock simulation video which is available on the YouTube. Please go through it. That is Martin Bromley. He is an pilot. So he compared our anesthesia intubation as a for his simulation. So pilots have simulation, so why can't anesthetist have? So he started, and then the guidelines and all came into place after Elaine Bromley case. So today we have a simulation course that is, and which should be repeated every 6 months. And first and foremost, a simple request to all of you all here, go back and have your difficult airway trolley cart ready. Make it for anticipated, of course, you have an fiber optic bronchoscope, and this is an updated guideline on equipment, which was 2012 these guidelines came, and now it is 2022 they updated, which goes to say all this right from the first lecture we are listening is keep a difficult airway trolley ready. Equipment should be stored in difficult airway trolley. It should be easily recognizable, readily accessible, clean labels, readable, and facilitate its efficient use. The purpose should be clear. Any equipment you cannot keep buying, the management will not. So the equipment should fit the purpose with evidences supporting it before the purchase is made and its clinical use. Okay, backup equipment should always be ready. Your ventilator can conk off, your ambu bag should be ready. So you have to always keep the backup if the first line equipment fails. The guidelines, cognitive aids, and emergency contact number should be very nicely, readably written and laminated and attached to your difficult airway cart. Safety culture to the difficult airway trolley and grab bags. Like a freelancer carries his own bag, you should have a regular audit. Check the absence, the malfunction, the damages, the contamination, expiry and misplacements, and do the needful. Recognized infection controls complying the national and the industry recommended protocols should be followed. Effective and timely training or regular education such as these workshops should be regularly attended. The capnography is mandatory and should be accessible immediately to any corner of the hospital where a difficult air intubation is being conducted. The grab bag, this is for the freelancers. The portable emergency bag for rapid deployment to the areas not easily accessible should be present, but this is not a replacement for the difficult airway cart in the OR. You have to see which key fits the lock and keep your equipments. You may not have all the equipments, but what you have should be properly in place and easily accessible. Thank you.